Okay, so this chapter is chapter 46, and this is your bowel elimination chapter. So we're going to talk about the bowel elimination, which, as we all know, this is something that our body normally does. It's very important for us to monitor our patients' bowel movements because we will have patients that are hospitalized, many times become constipated during hospitalization, and people aren't monitoring this very closely. And part of the reason is immobility, um, medications, especially post-op patients that will take a lot of narcotics. We know a lot of the narcotics cause constipation. So it's very important for us to constantly monitor their bowel elimination. It's very important for our patients to have their regular bowel elimination, and it's important to find out what the norm is. Some patients can have bowel movements that can be uh, once or twice a day, sometimes every other day, so it's important to understand what's our patient's normal bowel pattern. With this slide, it's just going over a little bit of the anatomy for some of you that have gotten a little rusty with it. Just keep in mind on the location of some of these areas. Part of the important thing with this is as we insert NG tubes and things like that, it's important to know where the stomach is and how the relationship is as close to the pancreas and the liver and the spleen, and how the anatomy just happens to lay. When we look at this picture in itself, we know we can always use the heart as a reference point, and you can take a look at how that's when you look at the heart right below, immediately right below, you have a part of the liver and stomach. A good way of remembering this too is dividing this picture into 4 quadrants and remembering what lays in that quadrant area. And as many of you know, that the GI tract needs high volumes of fluid in order to keep it in balance. Its electrolyte balance is a key for the function of the GI system. Also, in addition, it ingests fluids and foods, and the GI tract receives secretions from the gallbladder and pancreas. And digestion usually begins at the mouth and ends in the small intestine. The mouth mechanically and chemically breaks down these nutrients into a very small size, and it all begins once we start chewing with our teeth. Saliva is important. It's produced in our salivary glands because it helps dilute and soften our food for easier swallowing. And as our food enters the esophagus, it passes through the esophageal sphincter, and it's a circular muscle that prevents air from entering the esophagus and food from refluxing into the throat. It's important to make sure our patients are sitting upright, chewing carefully when we are monitoring them for meals, especially if they're at high risk for aspiration. It's important to monitor the patient. Make sure to explain to the patient to eat small amounts of food versus putting a lot of food in their stomach, and that's your high risk patients that are at risk for aspiration. Uh, Otherwise, just keep in mind that we do have uh, different secretions that are produced in our stomach. We have hydrochloric acid, we have mucose, enzyme pepsin, we have intrinsic factors, and all of these empty into the small intestine. This diagram here is just demonstrating a little bit on how peristalsis begin and how it works. It begins when we have different digestive juices that combine. They call chyme. Chyme mixes with these digestive juices and it reabsorbs back into the small intestine. So it's efficient. So by the time chyme reaches the end of the small intestine, it's like a paste-like consistency. And keep in mind that the small intestine has 3 sections. We have the duodenum, and you can reflect back on your other picture. We have the duodenum, the jejunum, and the ileum. It is very long, 8 to 11 inches. But do keep in mind that they all have different sizes and they all do different things. The jejunum primarily absorbs carbohydrates and proteins. You have the ileum, which is about 12 feet long. This one absorbs water, fats, and certain vitamins, iron, and bile salts. Then the duodenum and the jejunum absorb most of the nutrients and electrolytes. The intestinal wall absorbs nutrients across the mucosa and in the lymph of blood vessels. It's important to make sure that our patients have a good intake of fiber because fiber helps all the systems stay regulated, and the large intestine begins at the cecum. Here it's showing you some of what we talked about. How we talked about how the large intestine begins at the cecum. If you take a look at the diagram here, you can see where that lays, and you can also see where their appendix is. That's why when someone has a ruptured appendix, they can have a major infection because of you can see the proximity between the large intestine and the appendix. So it's a lot of bacteria, and it's not a clean area. That's why when this ruptures, it does put our patients at risk for a severe infection. Um, there's nothing more as far as if you want to read more on this. Your book does cover some nice information if you could be a little rusty with the anatomy of the large intestine. Some of the knowledge you need to know that digestion does begin upon mastication. So the moment you start chewing, digestion begins. You have the esophagus, and with the peristalsis, moves food into the stomach. As many of you know, if food happens to get lodged into the esophagus area, the normal response for that is to get hiccups. Then you have your stomach, which will mix food, liquid, digestive juices, and it moves food into the small intestines, which that's your next portion. Your small intestine, remember, it's divided into three. In your small intestine, you have your duodenum, your jejunum, and your ileum. You have the large intestine, which, like the primary job of the large intestine, is to make sure it softens your stool. That's why it's important to have adequate amounts of oral intake liquid, water, to make sure the stool is soft enough and our patients do not develop constipation. We definitely don't want patients that have any type of cardiovascular disease, glaucoma, or intracranial pressure to become constipated because they will have to do a Valsalva maneuver when someone was strained. We want them to avoid straining because if they strain, they can go into cardiac dysrhythmias. They can actually slow their heart rate down. So it's important to make sure people that have cardiac problems or at high risk, they take stool softeners. This is just another one showing you factors that can affect bowel elimination. We know that with age, everything slows down, especially the older adult. That's why many of you perhaps have experienced that your older adult patient is very fixated on bowels. They know that it's very important to go, so they will keep a very close eye making sure that they are having bowel movements regularly. Fluid intake, I talked about that in previous slides, that it's important to have adequate amounts of fluid intake, and we're talking about water, not types of fluids like coffee and soda, because as you may already know, those are diuretics, so you'll actually worsen a constipated patient by giving them those type of items to drink. As far as psychological or psychological factors, um, keep in mind that sometimes that will play a role when someone has, like they say, a form of ostomies or any kind of developmental changes that can affect their elimination. Uh, Position during having a bowel movement is important, as people that have worked in acute care know that there's many patients who will not be able to get up and use the restroom, and they have to actually use a bedpan, and it's very difficult for them to try to use a bedpan while they're in the bed, and many of them will prefer not to go. They actually try to hold it until they're able to ambulate into a toilet. So if you do have to have them use the restroom in the bed by putting a bedpan under them, make sure that you elevate the head as much as possible. That way, they are able to go normally. And I did want to reinforce that as far as fluid intake, it's important for patients to drink anywhere from 1.5 to 2,000 liters daily. Uh, that's important for them to have adequate amounts to liquefy their stool. With pregnancy, it puts pressure on the rectum, so it can cause obstruction. With this pressure, they have a slow process of their peristalsis, especially during their third trimester, so many of them will get constipated. Now, as far as medications and laxatives, it's very important to educate our patients not to overdo it, because when they take too much of this, their body becomes used to taking laxatives, and they won't be able to go normally because these medications affect bowel functioning. So it's important that they don't overuse laxatives. Diet. I talked earlier about diet. It's important for patients to follow a diet that is high in fiber. That's important. Physical activity. People need to keep moving because physical activity promotes peristalsis, and inactivity slows down peristalsis, which is why people get constipated. Trying to keep people as much as possible can with personal habits. Um, like I said, some of them they rather use a restroom rather than a bedpan. And with surgery, we know that a lot of patients after surgery will have what we call a paralytic ileus. And what that is usually anywhere from 28 to 48 hours, a patient will not have any activity in their bowels. So when you auscultate, you actually won't hear any bowel sounds. So that's called a paralytic ileus. If you want to break it down, the, the ileus has been paralyzed due to the general anesthesia. And as far as diagnostic tests, we have endoscopies and colonoscopies. Uh, Everybody will have a colonoscopy by the age of 50. That's a something now that every physician is doing to prevent people from having or finding early signs of colon cancer. And here are some common problems that some patients may experience. We have been talking about constipation, and with constipation, we know that it's actually a symptom, not a disease, and it can be from improper diet, reduced fluid intake, lack of exercise, certain meds. Um, we talked about opiates. Signs of constipation, you can say if it can be infrequent bowel movements. Usually, people that will have one every 3 days, that would be considered constipated. And it is a health hazard because straining during defecation causes problems for patients, especially if they're post-surgical patients. I did talk about how they can actually go into dysrhythmias. Um, Vagal stimulation slows the heart rate, and there have been many people that have coded from straining. Some of them, I don't know if you ever heard of people people just dying when they're trying to have a bowel movement, that's usually because they get so constipated that they'll strain for such long periods of time that they'll overstrain their heart because they'll slow it down. We know that currently we have a lot of problems with diarrhea in the hospital. We are now isolating all the patients that either have a history of diarrhea. As soon as they come into the hospital, we are isolating them, putting them on C. diff precautions. Also, if a patient develops diarrhea in the hospital, uh, they will also be placed on C. diff precautions. So, because it is so contagious that now we rather rule it out and treat them rather than send in a specimen, wait for the results, and then treat them, because by then people are not doing the proper hand hygiene. And as we know with C. diff, everybody must wash hands with soap and water because it is a spore that will not be killed with the alcohol disinfecting solutions we use. If someone becomes impacted, it is incredibly uncomfortable for the patients. And one of the quicker signs of realizing that someone is impacted is when they're having loose stools. I'm sorry, not loose stools. They're passing like a liquid stool, and many times people will unfortunately confuse that as a bowel movement. They'll put that as a smear and continue to document smear, spear, when actuality the patient is severely constipated, and the body is trying to push out. That is actually, well, if you think about the intestine, there's like a piece of stool stuck in the intestine, and the body is straining so hard to push something out that by the time it reaches outside the rectum, it's liquid. So make sure you are doing good assessments and making sure that that liquid is not an impacted patient. Incontinence, a lot of patients become incontinent, just inability to control the passage of feces and gas. Flatulence, important to have that after surgery. Many times you'll hear the doctor ask the patient a few times, are you passing gas? Are you passing gas? Because it's the beginning of peristalsis. And hemorrhoids. Hemorrhoids are very painful, and we don't routinely see a lot of this in the inpatient setting. You might see more of this in the outpatient setting. And there's a lot of over-the-counter items and medications that the patients can use for comfort with that. Now we're switching gears to bowel diversions. With bowel diversions, they can either be temporary or permanent. We know that is an opening to the outside of the abdominal wall, which will form into what we call a stoma. So stoma is surgically made, and it can either be an ileostomy or a colostomy, and it all depends on where the opening is made. That will determine what it is, whether it will be an ileostomy or a colostomy. And if you kind of think about the name in itself, the name has where it is. So if it's an ileostomy, it's in the ileum, and if it's a colostomy, it's in the colon. So if you want to refer back to the picture that we showed you earlier, I'll kind of give you an idea on where it would be. And with a standard bowel diversion, sometimes the patient will need reconstructive surgery to close it up, and sometimes it's a permanent ostomy. So just have to educate the patient on how to care for these ostomies. This diagram here is showing what we call a loop colostomy, and what it is what they do is they put like a little plastic rod, and this is for temporary fecal diversion. So if they do have this, you know that it's not going to be permanent. It's just temporary. When they do this, it's usually done under emergency purposes, and the physician anticipates in closing this and making sure that the patient will have regular bowel movements once whatever area needs to have that bowel rest, and they'll go back and close these two openings. Usually, um, within 7 to 10 days, the surgeon will go in and remove that little supporting device that you can see in the diagram. This picture here is in colonostomy. So if you can see by the name in itself, also it's um, end. It's an end portion of your intestinal area, and it's usually it's in the descending or sigmoid colon is brought out through the peritoneum, and the muscle then is sutured to the skin. This one here can also be called Hartman's pouch, and for many patients with colonostomies, it's usually because they have had colorectal cancer, and the rectum for a lot of these patients is completely removed. So this one here is more of a permanent. Just depends the patient situation. Sometimes if patients have diverticulitis who are given surgery for the diverticulitis will have a temporary anstoma. Those will be temporary. So like I said, it just depends on each patient scenario. In this diagram, you have the double barrel colostomy. So this one actually has two stomas. It's not very evident when you look at this, and I've had students ask me in the past if this patient would have one device or two. They actually have they'll have one device or one stoma bag over both of these. And this one, once the area they needed to heal has healed, they'll go back in and reconnect those two and make it intact. Ostomies is just almost like a just letting you know the ones we talked about, giving you a little bit more information on them. And just remember, the location of the ostomy is will determine the consistency of the stool. It can either range from liquid to formed. It just depends. If it's performed in an emergency basis, it's usually going to be a loop colostomy, and an end colostomy is usually done for cancer, and it is a permanent procedure. It just depends on why it was done. And then you have the double barrel, in which this one can be reversed. This picture is just showing you the different kind of pouches they can make for people that opt out not to have stomas sticking out. These are just alternative approaches. You can take a look at these in your book if you want more information. I'm not really going to ask you too much on these, so the next few slides I'll just skip them. This is another one just showing you a diagram of what it looks like. And this one here is called a MACE, but that's what it stands for. Masita Malone Anti-Grade Continence Enema. And this is actually showing you the 4 different types of surgical procedures that can be done. And what this is for is improves patients that are what they need help with continence. So it improves continence in patients that usually will have fecal soiling that secondary to some kind of damage, permanent damage they may have, either neuropathic damage or some kind of abnormalities of the anal sphincter. And with this one, they'll usually put in a Foley catheter in the place, and it's like it has a small opening, and you put the patient will be taught on how to do enema administration 7 to 10 days after surgery. This type of patient receives daily enemas, and the volume of the enema will vary depending. And this enema takes anywhere from 45 to 60 minutes to administer. And then a few minutes later, anywhere from 30 to 60, evacuation begins. Uh, this is just showing you the alternative approaches that we talked about in the other slide. And here is an NCLEX style question. A newly admitted patient states that he has recently had a change in medications and reports that stools are now dry and hard to pass. This type of type of bowel pattern is consistent with A, abdominal defecation, B, constipation, impaction, or incontinence. And if you were thinking B, that is correct. That is constipation. Right? I did talk about how some of the medications and diets, not enough fluid intake can cause constipation. And then as far as when you're taking assessments or you're intaking these patients, some of the questions that is important to ask is, first of all, if the patient comes in with abdominal pain or any kind of elimination problem, we want to make sure that we do a very thorough focus assessment, concentrating on bowel habits, factors that influence defecation, any kind of changes they may have, their abdomen, what does their physical and exam look like. We want to know what are their patterns of defecation, and we want to know if they're having any diarrhea, if they're having constipation, do they take any aids to go, such questions like that too. Here's a little bit as far as assessment. We're going to look at an GI assessment includes the mouth, the abdomen, and the rectum. You're going to look inside the mouth, make sure that the patient is well hydrated. Remember that looking into the mouth is a good indicator of hydration, and also we can look at their dentition. Do they have dentures they fit? Do they have no teeth? And if they have no teeth, then that changes their ability to eat. So perhaps you may want to get them a puree diet because they're not going to be able to chew. So it's important to look at the teeth as well. You'll be looking at all the 4 quadrants of the abdomen, and some laboratory and diagnostic tests can also be done so we can see if the patient has any ongoing problems with their GI tract. This picture here is just showing you what a fecal occult kit looks like. These are used done to clinic, and just get a small piece of stool, put it there, and add the dropper to it, and we'll let you know if someone is positive or not for FOB. This is just the same, it just continues. Some of the diagnoses you can use is, of course, constipation, risk for constipation. Anybody who's taken narcotics will immediately become a risk for constipation. Toileting, self-care deficits, any kind of incontinence. So what are we going to do? We're going to make sure that we promote normal defecation. We're going to try to establish a routine as best as possible, especially with your elderly clients. It's important not to give them, if we're talking about urine, it's important not to give them too many liquids at a certain time. And sometimes when we're trying to train our patients to have a normal pattern, we can always have them go 1 hour after a meal. And it's important to try and maintain their normal habit as much as possible. If possible, try to put them in a sitting position. And when you put them on a bedpan, make sure that you sit them up as best as you can. Do assess what the stools look like. Make sure there's no blood. What color is it? The consistency, because that tells us a lot about what's going on with our patient. Just to try different types of bedpans. The smaller bedpan is a fractured bedpan, and then the other one is just a regular bedpan that we use for most patients. This picture here is just showing you good positions to put your patients in when they're mobilized and they have to use a bedpan. Obviously, the proper one is the top and the improper is in the bottom. It'd be very difficult for your patient to have a bowel movement in that position. This one here is just showing you how we would put the bedpan and remove it. As far as laxatives and antidiarrheal agents, it's important not to overuse because overuse will mean that they will disrupt their normal pattern. And quite honestly, sometimes if these are overused, it actually does a negative effect. So people actually become constipated. When we are giving medications to give diarrhea, it's important that we are keeping an eye on our patients' lab values. As you may know, or hopefully you remember, that when someone is having a lot of loose stools, they lose a lot of potassium. So you want to make sure that you are taking a look at that when you have patients that have diarrhea. And any patient that has diarrhea that's usually longer than 2 days, you need a stool culture. So make sure you're informing your physicians about their pattern, and if anything looks abnormal or needs to be addressed, make sure you let your physicians know, because many of them won't know anything about the bowel pattern unless you tell them. And these are the different kind of enemas that you use. There's cleaning enemas, tap water. We have soap suds. With soap suds, uh, this one is one that can what it does is creates effective intestinal irritation to stimulate peristalsis. Comes with a little castile soap and is in liquid form. And make sure that when patients have any kind of preps that they need to go to, like tests, if they're going to have a colonoscopy and they have a prep, make sure that the patient has done the full prep and that their colon is clean, because if they don't, uh, they can be rejected when you send them down for their procedure. Uh, there's there's different kind of medicated enemas. We do have here KXLate. With KXLate, do keep in mind it's an example of sodium polystyrene sulfite, and it's used to treat patients with dangerously high serum potassium levels. So that's why, remember when I mentioned earlier that when someone has a lot of diarrhea, they start losing their potassium. Well, with KXLate, is one of those drugs that doesn't work as fast as other drugs when we're trying to control potassium, but it is another type of medication we can use for to reduce the potassium levels. And then, as you know, that enemas are not sterile, and there may be times that you may have to do some digital removal of stool. If the patient is unable to pass the stool, they will need assistance with it. And make sure that when you are uh, doing a digital removal, leave that as your last resort, because it's uncomfortable for the patient. It causes a stimulation of the vagus nerve, which can slow the heart rate down again. We've actually had patients code in our facility after they've been in the middle of a digital disimpaction, because will braiding them so low that they actually become unconscious. So, like I said, leave that as a last resource to try to have your patient go. NG tubes. It's important to Make sure that when you are inserting these NG tubes, you know the reason. Like, what are we giving it? We talked about this when we did our checkups for NGs, or when we do our checkups for NGs. It's a decompression, or either we're gonna give enteral feedings or we're gonna do a lavage. There's different reasons. Also, there's different sizes. You have fine or small, and then you have large, which is 12 French or above, which are usually used for decompression and removal of gastric secretions. It is important to do a clean technique and maintain patency. With patency, it's important to always flush your NG tubes before and after. And before you give anything through that NG tube, make sure that placement has been confirmed with auscultation and making sure you're checking that pH. And if your patient is getting a chest x-ray, there'll be a read on your NG tube position as well, so make sure you're looking at that. Here's another question. So, to maintain normal elimination patterns in a hospitalized patient, you should instruct the patient to defecate 1 hour after meals because if you picked B, or we're thinking B, that's correct. Because remember that peristalsis begin at the time of mastication. Continue in restorative care. It's important to know the different care of ostomies, and we do have nurses that specialize in this. WOCN nurses, they have specialty. They're very well trained. They know how to teach patients how to deal with ostomies, and nutrition is important because you need low fiber for the first 2 weeks because we don't want these patients having diarrhea either. So it's important that we teach them what they need to eat, different kinds of foods, avoid gassy foods because we don't want the ostomies to get full of air because that air will cause will cause blockages. So it's important that you release that air. And if you've ever taken care of someone with an ostomy, it's not the easiest thing to do because it can be very odorous. Instruct your patients to drink anywhere from 10 to 12 glasses of water daily. This is just showing you how to irrigate a colostomy, and it's not very common as it used to be. So it's not done that often. A lot of times, some of the patients are taught to do this when it becomes hard for them to go. Make sure that you teach your patients to never use an enema to irrigate a colostomy. They give them a special device that they can use to instill solution. And anytime a patient is getting an enema, it's important that if you're doing like a soap size or any kind of irrigation type of solution, keep in mind that the higher you put your bucket, the more that goes in quicker and can cause a lot of cramping. So you don't want your patient to experience that. So you want to make sure that you take your time and you do it correctly. Bowel training, important diet, regular exercise, and of course, if they have hemorrhoids, we got to make sure that those are being addressed and that the patient is getting the proper treatment because they're very painful and uncomfortable. So just with everything else, you're gonna go back and evaluate. Does the patient require medications to go? Are they able to go on their own? Make sure that the patient's taking a diet with enough fiber in it. Make sure that they're drinking enough fluid, and take a look and see what kind of challenges you've encountered and see what things you can do different to make sure that your goals are met with each patient. That concludes your bowel elimination PowerPoint. Remember, if you have any questions, feel free to email me.